How is lymphopenia monitored when taking oral MIS treatments? When managing multiple sclerosis with oral medications, keeping an eye on lymphocyte levels is a key part of ensuring safety and effectiveness. Lymphopenia, which is a decrease in lymphocyte counts, can happen with some of these treatments. Since lymphocytes are a type of white blood cell important for fighting infections, monitoring their levels helps prevent complications like infections or other health issues. Before starting any oral disease-modifying therapy, doctors usually perform a complete blood count test. This test measures different blood components, including lymphocytes, and helps establish a baseline. Knowing your baseline lymphocyte count is important because it allows your healthcare team to see if the medication causes any changes over time. Once treatment begins, regular blood tests are scheduled. For many oral therapies, blood counts are checked every 1 to 3 months during the first few months. For example, if you are on dimethyl fumarate, your doctor might order a complete blood count every 2 months for the first 6 months. After that, if your count stays stable, testing might be spaced out to every 3 months. For teriflunomide, blood tests are typically done every 2 months for the first 6 months, then less often if everything remains normal. Cladribine requires monitoring before and during treatment, especially in the second year, to ensure lymphocyte counts stay above certain levels. There are specific thresholds that guide what action should be taken. For example, if lymphocytes drop below 0.5 billion cells per liter for more than 6 months while on dimethyl fumarate, your doctor might pause or stop the medication. In clinical trials, fingolimod treatment was sometimes interrupted if lymphocyte counts fell below 0.2 billion per liter, although post-marketing data suggests that severe lymphopenia does not always lead to infections. For teriflunomide, treatment is usually stopped if lymphocytes fall below 0.5 billion per liter. Cladribine treatment requires lymphocyte counts to be at least 800 cells per microliter before administering the next dose in the second year. It's important to interpret lymphopenia in the context of each medication's mechanism and your overall health. Not all decreases in lymphocyte counts mean you need to stop treatment. Sometimes, a mild or expected drop is manageable with close monitoring. Your healthcare provider will also watch for signs of infections, especially opportunistic infections like progressive multifocal leukoencephalopathy, which can be linked to very low lymphocyte levels. If you start with low lymphocyte counts before treatment, your doctor might schedule more frequent tests. In some cases, if lymphopenia becomes severe, treatments like teriflunomide have protocols to help clear the drug faster. Before starting therapy, screening for infections such as hepatitis B and C, tuberculosis, and varicella zoster virus is also recommended to reduce risks. In summary, monitoring lymphopenia during oral MIS treatments involves initial baseline blood tests, regular follow-up blood counts, and paying close attention to specific lymphocyte thresholds. This careful approach helps your healthcare team balance the benefits of controlling MIS with the safety of avoiding infections. Always discuss your individual situation with your doctor, as they can tailor monitoring and treatment plans to best suit your needs.